My dear viewers, we have Dr. Sridevi with us. Doctor, how will you treat diabetes in pregnancy? Can you please share?
Sure, thank you. So this is very important to know what can be done, because if we have an adequate control, we can prevent most of its complications. So how do we manage it is by blood sugar. We check their blood sugars regularly, like for example fasting and after food. So depending on that, the treatment can be done. So before that, the most important thing is lifestyle modification, that is diet. So in diet, what happens is a balanced diet should be given, and instead of 3 full meals, we should ask them to take 3 meals and 3 snacks, so that we are splitting the amount of glucose at one point of time. And also the amount, for example 55% carbohydrates we ask them to take, and also around 25% fat, and only 10% should be saturated fat, and around 20% proteins. So this is how we ask them to take, and most importantly it should be split meals. It's not at one time, they have to split the meals and take it. And everything with a low sugar content. As we said, low glycemic index food like non-starchy carbohydrates can be taken, because it doesn't increase the blood sugar directly. Also, exercise is very, very important. So along with diet and exercise, first we will try to control the diabetes. In pregnancy, we call that as gestational diabetes. So with this, again, we check the blood sugars and we see if it comes under control. Exercise means maybe walking. So around regular exercise and diet should be able to bring the blood sugar in control. If it is under control, it can be maintained with that. But even after 1 to 2 weeks, still we are not able to get the blood sugars under control, then preferably we start them on insulin, because we want to treat it, because we want to avoid its complications. So it's better to be treated. And more than oral hypoglycemic drugs, some people can take oral hypoglycemic drugs, but the advised drug, the first choice for diabetes is insulin. And you don't have to be worried. Insulin, it's an injection. It's not very since it's given subcutaneously, it's not very deep, so it's nothing to be worried about, and its advantages are much more. So surely when a doctor advises you to be started on insulin, the advantages of insulin are much more, so surely it should be taken. And regularly they will be monitoring your blood sugars, and according to that we can either give short acting insulin alone or intermediate acting insulin. That will be judged by the obstetrician with your blood sugar. Sometimes you may even need admission for the control of blood sugar. So or it can be given in split doses. So they will calculate the total amount of insulin needed randomly. We say around 0.7 unit may be needed in the first trimester per kg, 0.8 in the second trimester, and 0.9 to 1 unit per kg in the third trimester. Roughly it's calculated like that, also varying on the blood sugars. So the total dose, again, we give the 2/3 of the dose in the morning and 1/3 of the dose in the evening. The 2/3 of the dose again is given with short acting as well as with intermediate acting. So with about 30% of the insulin will be short acting and 70% will be an intermediate acting. In the night, 50% is a short acting and 50% is an intermediate acting. Why do we want to combine this kind of insulin? Is each has a different onset of action and a different peak. So overall, throughout the day, you can keep the blood sugars under control. Because the short acting, we may get a peak in 1 hour, whereas a long acting, the peak comes about 6 hours. So it maintains an overall for about 12 hours. You can have complete control. And again with the night dose. So this is about insulin. It should be taken correctly. And the patients can take it. Now there are easier forms, for example, pen, where self insulin. You don't every time need to go to the hospital to have the injection. They will teach you the correct technique and the correct site to put. It's usually given subcutaneously. So that's in the fat. Some people prefer putting it in the thigh, some people in the abdomen because they feel lesser pain. So so wherever site, and since you're pregnant, preferably maybe the thigh may be a better site. Some may prefer the arms. So whichever is preferable to you, subcutaneously you can give. And the most important thing is the blood sugar should be monitored correctly. Sometimes even up to 7 times we take a blood sugar after every meal. because we want a tight control. A strict control is very important. So this is, and drugs like metformin may be given, but usually we start them on insulin, and we have to monitor for the other complications. And we also want the baby to be fine, because as the most important complication is suddenly the baby may die. So we do a biophysical profile, NST, all that say that the baby is doing fine. You have nothing to be worried about. So, and also the diet and exercise, even with insulin, the diet and the exercise should be maintained, and you should avoid taking direct sugars, for example, white sugar or juices or any aerated drinks. All that which aggravates the complications should be minimized.
Yeah, as rightly said, lifestyle modification, tight control of blood pressure and sugar, and third is obstetrical management. When the timing of delivery.
Yes, yes.
That's what doctor said, the biophysical profile. That is nothing but seeing the baby, 5 components: fetal heart, fetal tone, how it moves, breathing, how the reactivity, the amount of fluid. These are seen so that we know, yeah, this is the time the baby need to be delivered.
Yeah, usually we don't allow them to go more than 38 weeks.
Yes.
Because sometimes 38 weeks the baby is very well, it's a term pregnancy, and so because future that 2 weeks they may go for a sudden death, so we don't want that to happen. So usually in diabetes it's preferable to be delivered by around 38 weeks.
Yeah, most of the time. So obstetrical management, when to deliver, and delivery of the conduct of labor, how to conduct during labor. That is, you give insulin and IV infusion. It has to be monitored, and cutting short the second stage and preventing infection and taking care of the baby. These are the components of management. Principles, as told, is not simply giving insulin. The patient has to be admitted in the hospital, sometimes 5 to 7 times they check the blood sugar. Then they find out what is the ideal dosage, total dosage, as told by doctor. It can be split into plain insulin and intermediate reacting, morning and night. The schedule in different schedule. They also take the advice of diabetologist. Then ideal thing can be maintained, and really thank you, doctor.
And also one more important thing, when they have diabetes, this is about gestational diabetes. So when they have diabetes in pregnancy, in the first visit itself, we see what all drugs they have been taken. And usually, since pregnancy itself, there's a chance of increasing the diabetes, so we change mostly to insulin. So the first visit itself, if you're a previous diabetic, it has to be consulted immediately, and whether that tablet has to be changed to a insulin, or whether it can be, the dose has to be changed.
Yeah, and they are prone, as told by some videos also, congenital anomaly for the baby. They are also prone for cardiovascular. So sometimes echo is necessary. And they are also prone for increased blood pressure. That has to be checked. With all that, probably once it's controlled, we can have a very beautiful and safe mother and safe baby. Okay? Okay, thank you, doctor.
Thank you.